Okay, anyways, good evening. Today's class is on uterine manipulation and the practical approach of it. So we'll start directly with the presentation. So first and foremost, basically the session was on uterine manipulation. So not to stretch it too far, we'll directly dive into the topic. Uterine manipulation is basically of two types. It could either be a vaginal manipulation or an abdominal manipulation. Vaginal manipulation is one where we use the standard uterine manipulator. We only have a manipulator from below. We try to manipulate the uterus throughout the case using this. And in addition comes the abdominal manipulation, where usually myoma screw is the instrument of choice for abdominal manipulation, or you can even hand over an instrument to your assistant in order to manipulate the uterus or the mass which you are operating on. So many a times it is just purely vaginal manipulation. Sometimes it's a combination of vaginal and abdominal, and sometimes in advanced cases it becomes only purely abdominal manipulation. So we'll go through it one by one. So a lot of people ask me what is the uterine manipulator I use for my cases. So there are a lot of fancy names in the market which are highly priced, and to be very honest, I've never used any of them. Since my first TLH, I have been using this very simple uterine manipulator, which is just a valsalem with a sound. Uh, When I say first proper TLH, that is when I started in 2018. Before that I have experimented quite a bit here and there, but still, this is the most comfortable instrument I have found, where it's just a valsalem with a sound projecting at the end. So this is a very sturdy instrument. It's very economical. You'll get it in, I think, somewhere between 1,500 to 3,000 rupees. It's a very simple, even you can get it made in a workshop also. So you insert the sound inside the cervix into the uterine cavity, and you hold the anterior lip of the cervix, and you use it for manipulation. This works beautifully well for uteruses up to size 12 to 14 weeks, because till then what happens is the sound stays till the fundus, and the uterine mass is not so big that there will be a hinging of the uterine axis. So for uterus, which is 12 to 14 weeks, this works beautifully well. You don't have to have any kind of abdominal manipulation in addition to this. This will work. So this would be my preferred choice for uterine manipulation. Anybody who asks me, it's very cheap, it's sturdy. This can be used in almost all cases. But what happens is when the uterus size grows beyond 12 to 14 weeks, then what happens, the uterus is too big or the mass may be at the fundus, so there will be a hinging of the uterus. For example, the uterus stays like this if it's a small one. When it goes big, what happens if the manipulation is still here, this part, due to its weight, may go uh, get retroverted or it gets retroflexed. So this hinging angle happens, so which what happens is just uterine manipulation will not work. This mass is not going to move proportionately. It'll, because of this hinging, this angle, it will keep on dangling away from the uterine mass, and you won't be able to sufficiently retract or manipulate it just with the uterine manipulator. That is when you will have to start using some sort of abdominal manipulation, which could be what we'll be discussing further. So to uterus size 12 to 14 weeks, it's easily done with just vaginal uterine manipulator, but after that you need some sort of abdominal manipulation. I'm just stopping the screen sharing for a moment. So again, continuing with the class. So abdominal manipulation is mainly of two types. You can either use a myoma screw, or you can have an assistant using some sort of instrument to manipulate the uterus. So the good part about a myoma screw is you don't need to have an additional investment. Every lab kit usually have a myoma screw. It is very sturdy. Even big, large uteri, fibroid, everything you can manipulate with this. It's multi-purpose. But the problem when it comes to myoma screw is that when you fix a myoma screw at a particular position, then that position becomes very much binding, because if you have to realign the myoma screw, you'll have to take it out and again reapply it. The problem which happens is that the first site where you have applied it, then there is going to be bleeding or oozing from that particular site. It's not going to be life threatening, it's not going to be torrential, but that bleeding is going to completely soil your field and it is going to keep you irritated. So that is a problem with myoma screw. Once you apply it at one place, if you have to change the position, then becomes very difficult, because invariably large uteri you'll have to keep changing the position in order to get good assistance. And in certain cases like cancer cases, be it sarcoma or be it endometrial cancer, you cannot use a myoma screw because you cannot, there will be spread of the cancer. Yeah, welcome. Uh, Dr. Brahmalakshmi, welcome. I think you are the only person attending the lecture, but still I'm continuing. So basically what happens is that in infertility also, it is better not to destroy the architecture of the uterus. So it's best to avoid myoma screw in cases of infertility and cancer. So this becomes a limitation for using the myoma screw. But in the same time, if you have an assistant, as a good assistant who can manipulate the uterus abdominally from the accessory port, then that's the best option compared to anything else, because this is multi-directional. In any size, any case, any scenario, you can confidently use this mode of assistance. And there is no fixed position. Like if you want to keep on changing the direction of the uterus or the angle you want to make, because you're not invading the uterus, you can keep on changing the position, which won't cause any bleeding, any disturbance. And even in cases of cancer also, it's fine because you're not destroying the myoma or the architecture. But the biggest drawback of this kind of assistance is that it is totally dependent on an assistant. You have to have a very good assistant to make this possible, otherwise it's not very easy. So you have to train your assistant to a level that he or she can confidently assist you in all cases. So just to have a practical picture of this myoma screw, that is what is used for manipulation, abdominal manipulation. In our case, we use a tooth needle holder for assistant-based manipulation. So this needle holder is very sturdy. If you go for these hand instruments like the tooth forceps or any other forceps, what happens is they're not as sturdy as the needle holder. Needle holder is completely made with stainless steel. It is not detachable. It's one single unit and it is very sturdy. This is our preferred choice for abdominal manipulation based on an assistant. So in my own personal journey, the evolution has been that initially I used to use. Good evening, Lisama madam. Thanks for joining. So even in my personal journey, my evolution, how it has been is that we have been using the uterine manipulator initially, only the uterine manipulator, because the size of uterus which were operating initially was very small, like 10 to 12 weeks, bulky size, 12 to 14 weeks maximum. So uterine manipulator only used to suffice. But as the size of the uterus started growing and it became more and more complex, like we were going to 14 to 16 weeks, 16, 18 weeks, multiple fibroid and all, then we used to have a combination of the uterine manipulator and the myoma. So vaginal manipulation and myoma used to give us the desired manipulation for the case. But soon what we happened is that because of the disadvantages of myoma, which I have told earlier, myoma cannot be used in cases of infertility or cancer. Myoma, once inserted at a place, if you try removing it, it will cause bleeding at that side. It is going to be very disturbing. You cannot even cauterize that bleeding and stop it. So we shifted to having a vaginal uterine manipulator and then having an assistant who will manipulate it abdominally. So this was a very comfortable arrangement because both ways it is very beneficial. Uterine manipulator will give you that push and the assistant can manipulate the uterus whichever way is required. But over a certain period of time, what we realized is that when we started doing cancer cases, for example, endometrial CA, cervical CA, uterine manipulator is not allowed in such cases because they say there might be a spread of the cancer. It might distort the anatomy, it might distort the staging. So then we started purely changing to only assistant-based manipulation. So this does not happen in a day. So even for simple uterus, what we'll have to do is you'll have to start letting go of the uterine manipulator and only change to assistant-based manipulation so that when it comes to complicated cases like endometrial CA, cervical CA, or even some forms of endometriosis, sometimes what happens is the cervical canal is so stenosed or narrow that You cannot put any sort of uterine manipulator in. So you have to completely shift to only assistant-based manipulation if you have to do complicated cases. And finally, the best would be that you don't have any sort of manipulation, neither vaginal manipulation, neither abdominal manipulation. So you should be able to do without any sort of manipulation for up to at least 12 to 14 weeks size of uterus, so that even for the complicated cases, you'll be able to manage it. Most of these endometrial CA cases will be postmenopausal ladies with almost atrophic or a bulky uterus. So you really won't require a manipulation in any form. So once you practice without manipulation for 12 to 14 weeks size of uterus, you'll be able to do it easily. So in order to summarize, you slowly start with vaginal uterine manipulation because initially you'll be doing small cases, bulky 12 to 14 weeks. And then you slowly move towards a combination of vaginal and abdominal preferably assistant based because assistant takes time to get trained. And after that, you try to do it with none at all because then you will be able to manipulate any sort or operate any sort of uterus. Yeah, welcome Tejasri. We are almost winding up, but still you will leave it open for questions. So the summary is that never be totally dependent on instruments. You focus on techniques for doing a surgery rather than being dependent on instruments. Because the common question which a lot of people ask in the group, even when I go to operate at different places, is what is the kind of uterine manipulator used? Because there are n number of uterine manipulators in the market, ranging from what I am using. I'll just show the picture again. This is what I am using. One of the simplest forms of uterine manipulator. It will cost somewhere between 2000 to 3000 at the max. That is what you got. And from this range, you have got manipulators which are 1 to 1.5 lakhs also, named after a lot of stalwarts, a lot of people. To be very frank, to be very honest, I have never used any of them. And I've never once or twice somebody said try operating with this, and it was very difficult for me because I'm used to this technique. Since 2018, I'm using only this uterine manipulator for my cases. So that is in short, just to run through, this is the uterine manipulator, which works well from 12 to 14 weeks. You hold the anterior lip of the cervix and put the sound inside. When you shift to abdominal manipulation, either a myoma screw or assistant base. Myoma screw, the problem is that it's the good part is it's sturdy and multi-purpose. You don't have to have any additional investment. But the problem is it's fixed and it can only be applied in one place. And when you start changing the position, which you'll definitely have to as you progress in the case, the the previous sites where you had inserted the myoma, it starts bleeding. And this bleeding is going to be very irritating. You won't be able to cauterize it also, and it'll soil your field. And in cases like infertility and cancer, myoma screw will not be allowed. So best is to move to an assistant-based manipulation where you give a instrument to your assistant, and the assistant, he or she, can manipulate the uterus and create angles as and when you want based on the steps of the case. In any case, any scenario you can use, but the only limitation is that your assistant has to be that good. He or she, it'll take time to train. So in our scenario, we use this needle holder. Needle holder is the best for that because it's a very sturdy instrument, completely made of stainless steel. Using that, you can manipulate any form of uterus, any case, any scenario. So this was a evolution I had, which most of you would have, because we start basically with a uterine manipulator. Then you go with a combination of vaginal plus abdominal manipulation, which is usually the myoma initially. Then you move into uterine manipulator plus assistant based, and you have to finally move to assistant based only because in certain cases like cervical cancer, endometrial cancer, and all, you are not allowed to put a uterine manipulator. And even in cases of endometriosis, sometimes you won't be able to manipulate sufficiently with uterine manipulation. Another specific case is cervical fibroid. Sometimes cervical fibroid, the cervix is completely consumed and enlarged with a fibroid that you cannot put a uterine manipulator from below. So you'll have to completely depend on abdominal manipulation, preferably an assistant base. That was my summary. Don't be dependent on instruments. Be focused on techniques, how you're going to do. Use your manipulation to supplement your technique, not don't go by hard and fast manipulation techniques. So that's all from my side. Very short presentation. If you have any doubts regarding uterine manipulation which you want me to address, please feel free to ask.
Uh, Sir, can you elaborate more about the myomas, different positions of myoma screw for in hysterectomy?
Okay. So to be very frank, since last 3-4 years, I've stopped using myoma screw. So the thing is, whatever is your angle you want to make. Me being an ipsilateral surgeon, the angles I want to make will be different from what a contralateral surgeon wants to make. So it all depends on how you want to create the angles you want to operate. So there is no hard and fast rules that myoma screw should be applied this position, that position, or anything. It depends on how you want to manipulate the uterus to suit your style of operating. And as I said, because of the negative effects of myoma screw, I have stopped using myoma screw for last 3 to 4 years. Now I don't use it at all. It's either plain uterine manipulation or uterine manipulation plus assistant. If you have seen my videos, you will see a needle holder being coming from the other side and manipulating the uterus. I don't think there is any video where there is a uterine manipulate, myoma screw, unless and until it's a myomectomy. So does that answer your question?
Yes, sir. And which which needle holder do you use for manipulation?
I'll show you the picture. Just a minute. It's actually it's a plain tooth needle holder. Just a minute. Let me just share my screen. Yeah. Okay. This is the one. Can you see it?
Uh, could you enlarge the
Yeah.
picture?
It's a normal tooth needle holder. Tooth is necessary,
Okay.
because only then you'll be able to grasp the tissue. This is a piston handle type of needle holder. You can have a straight also, but piston handle gives that extra edge to grasp the tissue. The assistant will be more comfortable. It's just a tooth needle holder, which is completely made of stainless steel. This will suffice for almost all your cases. This is what I'm using. You can develop your own technique. I'll put this in the group also. And I think there were two questions in the chat. Okay. You're talking about needle holder as a manipulator tooth. Yes. Isn't it little small for holding on tissue? No, that much will suffice for, because if you use a tooth forceps, the jaw is going to be smaller than a tooth needle holder, and the grip is not going to be very good, and there is always a chance of the instrument bending when you apply pressure, but that is not going to be there with the needle holder, because the needle holder, the entire shaft is single and made of stainless steel. That is not so in instruments, because instruments have a stillet and a shaft which is different, and it is not as sturdy as a needle holder. So needle holder is always a primary choice. It's more sturdy, more strong compared to the, but if it's a small uterus, you can use a tooth forceps also. My suggestion would be to slowly move away from myoma screw as much as possible, because if you want to advance infertility cases, it's not really advised to use myoma screw. Cancer cases, you cannot use a myoma screw. So better to move from myoma screw, because myoma screw, once you apply it in one position, if you have to move that position, what will happen is that the first position where you have applied and removed it, there it is going to start bleeding. It may not be a torrential bleed, it may not be a life-threatening bleed, but definitely it's going to keep on oozing there, which may not be very easy to control with a bipolar forceps also.
So, and what about those V-shaped manipulators if we want to go for vaginal manipulation?
That's what I'm saying. I've never used them. I've been very comfortable with this particular manipulator, that I've never changed or experimented. When I have gone to some other places to operate, those doctors have suggested few this thing, but I never felt them comfortable. So this is the only manipulator which I have been using since last 7 years. Never had a problem so far. If you are,
And if I may add, Akshay,
yeah,
yeah, the V shape, the uterine manipulator that doctor was talking about.
yeah.
Actually, it has a disadvantage of that. It also that it wouldn't go into a nulliparous cervix. It wouldn't go through to reach the uterine cavity. And the second thing is when we try to lock it, it actually destroys the endometrium and a part of the myometrium, and it actually causes more trouble to us than helping us through the surgery.
This is the
That's something that
thing
I
is,
have
yeah, like
used and then abandoned.
enters like this, and when you lock it, it goes like
Yes,
this.
yes, yes,
Yeah,
yes, yes,
I've
yes,
not been
exactly.
comfortable, because there you don't have a grip on this. In this, you
Um,
manipulate, what happens is you're gripping the anterior lip of the cervix and the sound is inside. So when you move the uterus, the entire uterus moves as a single unit without causing much damage. But in this V-shaped thing, what happens is that there is ideally no grip on the uterus. So it basically has a very traumatic effect of divulging the uterus also, and there is no, what do you say, anchoring effect onto the uterus. I've seen some surgeons use it, but I was not comfortable with it. But if it helps you, if it is good for you, then you can go ahead. There's no hard and fast way. There is no right and wrong in laparoscopy or surgery. What suits each surgeon, that's the best for that particular surgeon. So, do you have any more doubts, Dr. Tejashree?
No, sir.
Anything you have, you can always post it in the group or you can post it in person. I'll share the recording soon of this entire talk in the group.
So if you would have that video of your this manipulation with a needle holder, it would be better, because sometimes, most of the time, what we get is an adenomyotic uterus where it's bulky, and
Yeah.
when we want to coagulate like the ipsilateral uterine artery or something, then like I feel it would be difficult with a needle holder to hold such a bulk of a tissue. So
Okay.
if it would be really helpful if you would share your video showing that manipulation.
No, but in every video I've put on YouTube, the entire manipulation is with the needle holder only.
Akshay, if I may,
Yeah.
the thing is, in those videos, like I've seen, I think most of your videos. I don't think I've missed any, but it is not. If, now when today you told me that it is a tooth needle holder, I wouldn't realize. Like it is not very obvious, because most probably that is something that you've been using so frequently that it wouldn't you know. Make you tell us that that is a tooth needle holder. So
Okay.
it is not obvious in any of the videos that it is actually that is the manipulator which is being used. Because I was trying to find out what is that you used to catch hold on to such strong tissue, like strong enough hold. That is something that even I was doubtful about. Yeah.
Okay. Let me also just go through the videos I've uploaded and I'll suggest to you the best video which has a lot of uterine manipulation being done with a needle holder. I'll suggest that to you because all the videos which I've done, which I've uploaded, are all done with needle holder only. There is no difference without any exception. These video recordings were started recently, since last 1 year, and I've abandoned the myoma screw for a long time. So myoma screw never comes into the manipulation aspect, only the needle holder. Let me see which video describes it best, or maybe next video when I'm making, I'll try to focus on that aspect and then I'll upload that.
Thank you.
Okay, so I think we'll wind up. Thank you. Thank you.
Thank you, sir.